We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses Endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we have now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology. We know that pediatric endocrine disorders are rare and they are complicated. They require cumbersome workup and expensive treatment. I already discussed about 2 common things, genetics and endocrinology. So we need to have tools which decide when you need a workup and what workup should be done in that regards. Now, we all read everything. We all have a lot of courses, books, everything is available. But then when you try to translate that into a clinical practice, the two-way communication becomes difficult. So we want to have a tool which can bridge the knowledge that we have and the clinical practice that we do. And therefore, this will guide your diagnostic tests, your algorithms, your treatment, and many other phenomena. So this is what we have been trying to do using mobile applications. And now we have got the MedEClasses Endocrinology application, the 3rd generation of which is going to be released in the next couple of weeks, which will have many more new developments. It's in fact the most downloaded endocrinology app with over 5,000 installs. We have already done a lot of validation studies which have been published, and it provides ways in which we can manage pediatric endocrinology Gynecology, pediatrics, as well as adult endocrinology to a certain extent, using pathways which guide you on approach, on management, so that you have a specific guidance which happens in this perspective. We also have developed analytics which will give you immediate interpretation of various functions like thyroid functions, bone age. Many of us are using the bone age tool. We are trying to incorporate AI-based bone age soon, so we are working on that regard, but it's going to take some time on that. And then we have developed interpreters like DSD interpreters, in which whatever we talk for 1 hour, if you just use that interpreter, you will get the right diagnosis in that regards. We also try to supplement with diagnostic information about the test and the therapeutic information. We're trying to put all the knowledge in that one app so that you can access and assess in that regards. So we'll try to see where it can be of various helps. The first, of course, is growth, which is the most common form of pediatric endocrine presentation that we have. And we know that there are algorithms which are available, but these algorithms are often not followed. And when we did studies, which Vibha will talk about, there are a lot of variations which happen even at a specialist level. Because number one, we don't plot on the chart. If we plot on the chart, we don't calculate the Z-score. We don't calculate the BMI Z-score. We don't calculate the height SDS for BA. And many of these parameters do not give us the right diagnosis in that regards. So we developed and validated a mobile application which provides growth interpretation based upon key inputs in that regards. And that was published a few years ago as part of this. Now, the second big problem which happens is that you have a problem of bone age assessment. And bone age clearly can be a problem. So in this growth interpreter, if you just put in the data with regards to the age, the date of birth, the parental height, you will get the interpretation there. And we have got very good validation on that regards. Now, bone age has been Achilles heel. Most pediatricians do not do bone age. And for pediatric endocrinologists, it's a burden because if you want to do it, it takes a lot of time. So what we did was that we developed ways in which bone age assessment could be done. And we developed and validated a tool with which a simple 5-site based you can do evaluation, in which if you select 5 sites, you will get the bone age. And this was published last year, in which we found that this tool was very good for comparison to the gold standard tools. And we had got good diagnostics even for the trainee. Now what we're trying to do is to club all that we have developed till now, the bone age, obesity interpreter, growth interpreter, to one tool, and that will be this bone age assisted interpretation of growth big. And Vibha has been also working in that regard. So please, over to you.
Thank you, sir. So after making so many interpreters and helping so many pediatricians as well as the endocrinologists, we decided to move a step forward. And so we decided to make a personalized, integrated, a point of care tool, which allows the usage by non-experts and it provides the instantaneous guidance. So with regards, we aim to develop and validate bone assisted interpretation of growth, that is BIG. It is a web-based tool for the guidance of assessment of growth and pivotal disorders. Basically, BIG is essentially a tool which requires the entry of key anthropometric parameters along with the pubertal status and the bone age. We can put the bone age either by selection of 5 specific sites or by manual entry options. And all these are analyzed and assessed by the logics which have already been fed in the portal system, which involves the validated and published into this algorithm for growth, for obesity, for puberty, both in girls and boys. And after this, this is analyzed by the algorithms, and this BIG will give the instantaneous pictorial growth chart, which shows the mid-parental heights and a detailed interpretation of the anthropometric parameters that are very useful in classifying the disorders of growth and puberty. Along with the interpretation, it also provides the initial workup that has to be done in both growth and pivotal disorders, and it also provides the bone age. As I already mentioned, it provides the bone age along with the BMI chart. This is how the BIG works. This is basically a web tool. This is not available in the mobile app. So what we have to do, we have to fill the patient particular details, the name, date of visit, gender, date of birth. birth weight, gestation, height, weight, sitting height, father's height, mother's height, tenor staging, and also the pubertal hair, this pubic hair. And then we select the multiple sites of the bone for the bone age, or we have the option for the manual input of the bone age. All this is analyzed by the algorithms which are fed in the portal system, and it provides the reports in this form, which includes all the parameters like corrected height SDs for BA, corrected height SDs for BA, and the bone age. So for this, with this regards, we conducted a study for the validation, which included 250 subjects, which presented to the Pediatric Endocrine Clinic between the December 2022 to July 2023, with the concerns of growth and pubertal disorders. These were analyzed by the BIG by giving all the anthropometric parameters, and the guidance of the BIG was compared with the guidance provided by the expert like pediatric endocrinologist, and the non-expert, the pediatric trainee and the pediatrician. Then all these guidance were compared with the gold standard, which was the final diagnosis and the management. And what we found in the result, the concordance score, the BIG has scored the highest concordance rate as compared to the pediatrician and the pediatric trainee. And with the use of BIG, importantly, the concordance, there is a reduction in 96% of discordance. And the discordance was mainly found among the pediatric trainees, and the impact of the discordance was they missed important pathologies by 20%, and they do the unwanted workup where the workup was not required in the normal cases. The errors were like the normal was diagnosed as short or precocious puberty and overdiagnosis of the endocrine etiology. But the BIG provided the reassurance and follow-up in 137 cases, and it misdiagnoses only 6 cases. So let's begin with the cases. How does the BIG work? It will be more easy to understand the functioning of the BIG with the help of couple of cases. So we have this 6 year and 6 month old boy with a concern of growth with a birth weight of 3.5 kg. He was full term. 96.1 centimeter was his height, weight 10.6, SMR, PH1, TV2, and the maternal height was 158.8 and father's height was 177. This was the bone age because we required the X-ray for the bone age, or we can directly enter the bone age. So this is how the BIG works. We have to enter all the initials, and after putting all these initials, we'll get this report. Now, the main thing is I would like to emphasize the details it provides. It provides the height SDH, which shows the boy has minus 3.61 standard deviation. Weight is minus 4.87 standard deviation, and the BMI shows that the weight is more affected than the height. So definitely it looks like a nutritional pattern, but as we compare it to the family, he's also shorter than the family, as corrected height SDS you can see is minus 3.24. And the height SDS for BA is minus 2.64, which is less than the minus 2. And if we see the growth interpretation, it clearly shows the patient has nutritional growth failure, and it guides the initial workup that has to be done in this patient. And the pubertal interpretation shows he has a normal puberty and nothing has to be done in this case, along with the bone age that shows he has a bone age of 5 years. This is the pictorial growth chart which shows the height and the birth weight and the weight, and clearly we can see that the weight is more affected than the height. Coming to the next case, we have the 16-year-old girl with growth concern. Birth weight was 3.5 kg, height 142.5 centimeter, weight 26 kg. Her SMR was B5, PH5, M1, and the maternal height 144.6, and father's height was 157.1. She has a bone age of 15 years. Now let's see what we'll get in the BIGS report. And what we see here, her height SDS is minus 2.37, definitely less than minus 2. His weight is minus 3.7 and BMI SDS is minus 2.9. From here, the growth parameter shows she is looking like a nutritional pattern. But when we look into the corrected height SGS, what it shows that it is greater than minus 1.5, which clearly shows she is fitting into the familial short stature, not the nutritional pattern. And what we get his growth interpretation that she is a case of familiar short stature with underweight, not the nutritional pattern. The initial workup was guided and she has a normal puberty. So no need for workup here. Moving towards the another case, we have this 12-year, 11-month-old girl with a growth concern. Her height 136.4 centimeter, weight 34.8 kg. She has a breast age of 3, pubic hair of 2, and not in Minaki is not attained. Mother's height 155.6 and father's height 167. No syndromic facies, no Turner stigmata. Here in this case, her bone is 10.7. So let's see what does the big will give us. Here, if we see the height SGS is minus 2.26. Clearly, height SGS is less than minus 2. And if we see the BMI SGS, it is minus 0.02. It means the patient is not the, she is not having any growth failure. And if we see the corrected height SGS, it is less than minus 0.5. Like she is shorter than than her family. And the height SGS for BA is minus 0.97, which means his height is comparable to her bone age. And when we see the growth interpretation, which clearly shows that his height is more affected than her weight, and it gives the endocrine pattern of growth failure. And the workup showed that all the screening tests has to be done, and if they came normal, the growth hormone assessment should be done. And the pivotal interpretation shows normal and no need for further evaluation in case of pivotal. So moving towards the next case, we have this scenario, and height is 128 centimeter at the age of 8 years and 9 months. At the age of 8 years, she has a breast age of 3, pubic hair of 1, and not Minaki, not attained. And here we do not have the X-ray, we just have the bone age. So as I already mentioned that bone, we can manually enter the bone age here. And when we see the results, what we found, she does not have any growth failure. And when we see the pivotal status, she is B3P1, and the pivotal interpretation shows that she has a slowly progressive central precocious puberty. And the pivotal workup, it gives the guidance for the LH, FSH, estradiol, ultrasound uterus, and consider even it also provides the guidance when to consider the GnRH analog therapy. If the LH is above 0.2 and the radiological features of progressive pubertal is present, and the endometrial thickness above 3 mm or uterine length above 3.4 mm is present. So with these data, we are very much close to make that diagnosis. Even we are not very much familiar with the textbook or the algorithms. This app provides details of these parameters, and even the guidance is provided. So moving towards the next case, we have this 17-year-old boy with a small phallic size, and he has a height of 162 centimeter with a weight of 49.8 kg. He has a SPL of 3 centimeter and TB of 2. At the age of 17 years, pubic hair 3, and the maternal height 168, father's height 177. And here also we do not have the X-ray. We just have the bone age. So with this bone age, we can evaluate further. So when we run the big, and here's the results, what we get. He does not have any growth failure. Now let's see what is the height, corrected height is this. He's shorter than the family. And the growth interpretation shows that there is no growth failure. He has normal growth. But in the pubertal interpretation, what we see, he has delayed puberty. And for this delayed puberty, the BIG provides the guidance for initial workup, like LH, testosterone, complete blood count, random blood sugar, sodium, potassium, ALT, creatinine, and TSH. So if I summarize what we decided to do, like we decided to develop an app which is personalized, integrated, and point of care. We have already made it, and we have successfully validated in 250 subjects. It allows the users by the non-expert it provides the instantaneous guidance. So I would say it is very much helpful for all the pediatrician and along with the pediatric endocrinologist as well.
Obesity also causes confusion, and we discussed about monogenic obesity, when to think of. So we have an obesity interpreter. Based upon the basic findings, we are able to really know whether this is a pathological or physiological form of obesity, which is there in that setting. Then we have this boy, 12-year-old girl with height of 130, weight of 58, and we can see she is short and she is obese, but she was reassured, came back to us with growth problem and was diagnosed as Cushing syndrome. But at the end, it turned out to be a pathological obesity. So it's very important to look at a proper assessment, and these tools can really help out in that perspective and regards. We have developed many tools with regards to the glucose disorder, and the pivotal one is the DK interpreter, which allows the management of DK based upon simple findings. Dr. Neha will be here, who is talking about different aspects. She showed in her study that the diabetic ketoacidosis and cerebral edema is extremely common in Indian children, and that is because of inadequate management. So there are guidelines which are there, but they are not properly followed up in that perspective. And when we studied our own children, we found that a substantial number of errors were happening even in our ICU, despite repeated training, despite a written protocol. So what we decided is to develop a sort of a new mobile application which guides the initial treatment based upon the weight, the pH, the carbon dioxide, the dehydration status, exactly what fluid you need, how much volume you need, as well as the follow-up based upon your responses, that now the sodium is 133, what do you do? Now the potassium is this thing, what you do? So this is something which we developed, and this tool was proven to be effective, and we published in that regards. And therefore, the other important factor in terms of glucose is how do we classify diabetes? Now, we saw this case of genetic diabetes where we found that there was a lot of fluctuations, but then we can miss this case. Like this is a 16-year-old boy who presented with obesity and type 2 diabetes in family, labeled as type 2 diabetes, but was not evaluated for autoimmune antibodies and was missed out and developed DK subsequently. So what we did here is that we have developed a diabetes algorithm which has been proven and incorporating the diabetes interpreter, which guides how much is the evaluation required and whether we are going to the right track or not. And this validation was done by Alapan, in which we involved the pediatric endocrinologist, the adult endocrinologist, and pediatricians. And we found that there were significant discordances which were happening in terms of the pediatrician, even the endocrinologist, and that resulted in missing and missing. So children who were having type 2 diabetes were being missed. Children who are having obesity with type 1 were misdiagnosed as type 2, and that will have implications. And therefore, if we use it properly, we will have a proper evaluation. The next major problem is the sick day management of children, and we have developed specific tools for insulin doses, correction doses, and sick day, which are used in terms of achieving the good outcome. Very soon, we are going to come up with a DiaBuddy app, which is going to guide individual recommendations based upon carbohydrate intake by children in terms of insulin dose, tracking their glucose, how much they are sleeping, how much they are eating, and other parameters will come in that perspective. And this is the way that the DiaBuddy will work on that. Now, one major challenge has been hypoglycemia, which has been commonly encountered in clinical practice. And this hypoglycemia will cause a lot of confusion in terms of evaluation and management. So now we have developed a glucose interpreter in which it will serially, you have to enter the various information and data, and then you will be able to identify the correct diagnosis and evaluation on that. So there are multiple tools that we have developed in terms of the management of wide variety of pediatric endocrine disorders. And we seriously hope that all of you would be able to access it, provide your feedback and how we can improvise on these tools and develop more tools. Because in future, there was a lot of debate today morning about AI and how AI can change things. I think AI best would be if you use AI properly and we are able to interpret things. Ultimately, we have to make the final decision, but we should at least get all the data in. So as Vibha was talking about, if you get all the data about height SDS, bone age, corrected height SDS, predicted height SDS, you will exactly know and manage it in an appropriate fashion. While if you just go by rough ideas, maybe plotting on the chart, you may not get all the information. So knowing more data will always be more beneficial in that perspective. And we have been trying to develop these tools subsequently, and hopefully over the time, we will be proceeding in that regards.